This is the Skin Science Podcast. I'm Dr. Thomas Hitchcock, and here we'll investigate everything skin science and dissect it from a scientific perspective, analyze it from a medical perspective, critique it from a consumer perspective, and give insight from an industry perspective. Hello, everyone. I'm Dr. Thomas Hitchcock, and welcome back to the Skin Science Podcast. And in the studio today, sitting in Angela McDonald's seat, we have Seti. Seti, introduce yourself. I don't think anybody's seen you other than in the Peanut Gallery before.
Yes, I'm Seti from Peanut Gallery. Somehow I'm sitting in front of camera today.
She's actually one of the producers, and Angela couldn't be here today. Not for any bad reason, for good reasons. But so I thought, who better to fill the consumer kind of role in our podcast today than Seti, who's actually been learning a lot over the last 2 or 3 years, doing our videos and producing the podcast and such. And so Seti, we'll talk about your Instagram and stuff later, because she has a lot of interesting things that she does behind the camera. But the other special guest today is this guy right here. This is Tyke. He is the Puzzle Beagle. And so anybody who watches the puzzle videos I do has seen Tyke from time to time. And he's actually really smart beagle, and I thought today we would bring a little bit of life to the studio by bringing Tyke the Puzzle Beagle, but he's not going to contribute to the dialogue, so he's going to sit down and sleep for most of the time there. But our special guest today, extra special guest, is Dr. Kyle Gillett, and I'm going to read a brief bio before he comes on camera, which is Dr. Kyle Gillett is a dual board certified physician in family and obesity medicine and attended medical school at the University of Kansas. He chose family medicine because he loves the variety and flexibility and the ability to treat the body, mind, and soul. Dr. Gillett enjoys providing holistic, individualized care to his patients. His practice includes preventative medicine, aesthetics, sports medicine, hormone optimization, obstetrics and infertility, integrative medicine, and precision medicine. Dr. Gillett describes the 6 pillars of health, and we'll ask him about that in a little bit: exercise, diet, sleep, stress, sunlight, and spirit. And he is the host of the Gillett Health Podcast. Welcome to the podcast, Kyle.
Thank you. I appreciate it. Pleasure to be on.
Yes. And so just so everybody knows, Dr. Doris Day and I were just on Kyle's podcast last week or so. I don't know when that's going to air, but it was a really great conversation. It was about the book that Doris and I just put out, Rebooting the Biome. And I'll actually have Alan add a little graphic of that in post-production so that we can show everybody that. And that's actually available on Amazon right now. But Kyle was kind enough to have us on there so we could talk about the book and what that's about. And now what I want to do is have Kyle on our podcast to talk about some of the things that I think that I've seen him talk about on his podcast. And one of the ones that Dr. Doris Day and I both thought was a great idea was the one for hair loss. And that's one because just like the biome, when it's not just about skin, right? It's about a holistic approach to health. So it's from the outside in, inside out. And that's where I really wanted to pull in some thoughts from Kyle about this, because it's not just dermatologists that are concerned with skin, right? And so, from a medicinal perspective, it's more than just skin that leads to things like hair loss. It's more than just skin that leads to, that's involved in the biome. And so to this topic at hand today is hair loss in men and women, similarities and differences, and kind of what's going on, what causes hair loss, how can we help to address hair loss. And I think there's a lot of ambiguity in the common vernacular about what causes hair loss. There's a lot of old wives' tales about what helps with hair loss. And so I thought we would dig in a little bit and bring some skin science, or I guess hair science, today to the podcast. So Kyle, if you could start by just giving us a little bit about your podcast, and I think there's a second podcast that you're starting as well, and then we'll dive into some of the questions about hair.
Yeah, definitely. As you mentioned, it's called the Gillett Health Podcast. It's mostly clinically oriented for clinicians and scientists, but we also occasionally do the after hours podcast that's more in layman's terms. And as you mentioned, we have had several expert guests on recently, such as yourself and also Doris. So we talk about a wide variety of topics, but the general term I'd call it is health optimization or cutting edge medicine, not bleeding edge. But things that are very popular and that are very commonly asked, but perhaps there's not very many evidence-based answers. For example, looking at the nuances of things like Ozempic or semaglutide, given that a lot of my background's in obesity medicine, that's a very common topic, or things like oral contraceptives, like the differences in progestogens and estrogens that are in those. So those are some common things that we chat about.
Okay.
So
Yes.
thank you for having us on there. Hair loss is certainly one thing that we talk about there quite a bit.
Yeah, and so I actually, Ozempic is one of those things where that's actually being looked at for anti-aging, right, as well, currently? I think that's been in the news about some billionaires who won't be named who are promoting that and saying it's the next best thing. Before we get into hair loss, what's your thought on that?
Yeah, it's interesting because when you look at GLP-1s, that's glucagon-like peptide 1, it's something that's produced in the alpha cell of the pancreas and also in the gut. It is also produced when you have a gustatory response from almost any food that you eat in different categories. But the dose makes the poison in this case. So taking very high amounts of it have lots of side effects. For example, gallstones or gallbladder issues or pancreatic inflammation. But low levels can preserve the beta cell of the pancreas, and a lot of them have a secondary indication, which is for preventing heart attack and stroke, known as ASCVD. That's especially in individuals who are diabetic. So a good rule of thumb is if you have diabetes or very close to it, then certainly it is a promising molecule. But if you don't, the harms likely outweigh the benefits.
Yeah, and I think that's actually something that I've been noticing in medicine in general, especially aesthetic medicine and anti-aging medicine or regenerative medicine, is that there's some people that think more is better. This mentality of more is better has way too much prevalence. And when it comes to evidence-based medicine, and there's things that we won't touch on today because it's outside of the scope of what we're going to talk about, but I would say actually hair loss is one of them, where people get supplements and think more is better, which can lead to stomach issues, digestive issues, and such. And so let's start by talking about hair loss in general. What are the thoughts about what causes hair loss? And it's going to be different between men and women. So give us a little bit of background about what causes the beginning of hair thinning, what causes in general across the board for men, women, and we'll start from there.
There are, of course, several causes of hair loss. Often when an individual is losing a lot of hair, it is a sign of something that has been happening for a long time, regardless of the process. So some people are familiar with anagen, catagen, and telogen phases. One of the causes is called telogen effluvium. Two common causes of telogen effluvium are iron deficiency and hypothyroidism. We see these very common after pregnancy because you lose a lot of iron, and also your thyroid hormone requirement is kind of on a roller coaster during the prenatal care and postpartum period. So that is one common cause. Another one is androgenic. So androgenic or androgenetic alopecia, that is hair loss that's secondary to any androgen binding the androgen receptor and its downstream effects from that. So what I mean by that is sometimes I call the androgen receptor the door, and the androgens can open the door. Stronger androgens open the door easier. Some people are born with a heavier door, like a metal door. Some people are born with a door that's like a light wooden door, hollow core, whatever you call it. I'm not a carpenter, and it opens very easily. And those people are more prone to androgenic or male pattern baldness. This can happen to some degree in females, but not as often because estrogen binding the estrogen receptor, specifically the estradiol receptor, can prevent the downstream effects. So even after that door is open, it can prevent the miniaturization and involution of the follicle. Some people are familiar with how the hair follicle has a stem cell, and the stem cell can either be present or not present. So when you biopsy the scalp, and I suppose this is how we transition things into derm, but when you biopsy it, it kind of looks like an autoimmune disease when you've had progression of many different types of hair loss, even if it's not presumed to be autoimmune. So you have a lot of inflammation. Even if it's not, for example, an autoimmune related hair loss, it can still look like that when you take a biopsy. And some of that is due to basically the stem cell leaving the follicle area. But at the end of the day, it's not necessarily always caused by an autoimmune process. It's a chicken or the egg. So that's how I explain. Yes, even with androgenic alopecia or your typical male pattern baldness without another pathology at play, some people think that treating with immunomodulators is the first way to go. But at the end of the day, it's important to think about the androgen that's binding to the androgen receptor and causing secondary effects downstream to that gene being activated.
Right. And so I guess let's start with just the one that's probably the most known, which is androgenic alopecia or male pattern baldness. And I think what you just said was an interesting concept, which is even with that one, it could be a number of things that are contributing. And we're finding out more as we go, which is not uncommon when it comes to medicine at today's age, where we have way more sequencing ability and all that stuff where we can actually dig deeper into science. But I guess my first question for you there would be, when it comes to androgenic alopecia, is there a discrepancy between the men and the women that see that? And do you know kind of any stats around that?
Yes, it most commonly happens in men. In fact, if you look at an average male and you take them to the age of 80, I believe 80% of men will have a significant or like a clinically significant amount of male pattern baldness at that age. So even if you take someone who is deemed not to be predisposed to androgenic alopecia, after a certain period of time, they will start to have the clinical signs, even if it's not frontotemporal, so it's done by Norwood scores, even if it's not regression of the hairline, you see thinning throughout, especially in the crown. And almost all men given an old enough age, kind of like given enough time and enough aging, all men will also develop prostate cancer, given enough time, theoretically at least.
Oh, wow. I didn't know that.
50% of men at age 80 develop prostate cancer, and probably 70 or 80% of men have what I would deem to be a clinically significant amount of androgenic alopecia. For example, you can debate Norwood 2, Norwood 3, like which one's clinically significant. But that's really up to the individual and what they're happy with.
Right, and there's a correlation between hair thinning or androgenic alopecia and prostate cancer, right? And so, do you want to talk about that a little bit?
A lot of that's probably related to a comorbidity, insulin resistance metabolic syndrome. So I would argue that the majority of people in this country and developed countries have some degree of insulin resistance, which I would define as a fasting insulin above 6, an A1C of 5.6 or above, or perhaps dyslipidemia with hypertriglyceridemia. So high triglycerides, and that increased fasting insulin is going to lead to dysregulated growth. So that's a lot of the kind of correlation between not just early hair loss and cancers, but also diabetes and cancers. If you look at an individual, for example, with type 1 diabetes, they have to take exogenous insulin because it's type 1 diabetes, and they have a significantly higher risk of various types of cancers, low IGF-1, which is growth factor, but very high levels of growth hormone, which is also related to cancer risk. But you would think someone with very high levels of growth hormone would have great quality and quantity of hair. That is certainly not always the case.
Yeah, and I guess the DHT that like things like finasteride and dutasteride can modulate. That is associated with both prostate cancer and hair. Those medicines, right? And so originally, I think finasteride was called Proscar. And then it was Propecia, just at a lower dose. And then there's the dutasteride, which I'm not sure what that's a generic name. I'm not sure what the brand name is for dutasteride, or if I'm saying that correctly. But they both act on DHT, and so we know, we know that that's actually associated, right? Is the DHT? And I'll ask you in a second. I just right before I said I was going to bring Tyke to the studio, Alan, the producer, was like, "Don't you think he's going to be a distraction?" I was like, "Sure he will, but that's going to be part of the charm of this particular podcast." And now I'm wondering how charming it really is. And so, hey Tyke, you want to come out? You want to stick? Okay, let's sit down. All right. So,
Yeah.
but anyway, DHT. Let's talk about that because. There's some interesting, and I don't know, do you know, I can't remember his first name, Mr. English. Do you know what I'm talking about? He wrote a paper about the tension of the scalp and how massaging it releases tension, and how the tension is associated with hypoxia in the scalp, which leads to conversion to DHT versus estrogen from testosterone. And I haven't really dug into that, but are you familiar with that kind of hypothesis? And do you have any opinion on that?
Yeah, there likely is merit to this, but again, it's a chicken or the egg situation.
Right.
Because what we do know is factual, is very high levels of DHT will lead to hypertrophy of muscles in the face and the scalp. So specifically high free DHT in the muscle. So even if your serum DHT, you take two individuals, they both have a serum DHT of 60 nanograms per deciliter. One of them is a high fasting insulin. If they have a high fasting insulin, it's very likely they will have a low SHBG. That's the protein that binds up androgens. And that protein, again, called SHBG, very strongly binds DHT. So these two individuals could both have a total DHT of 60, but one of them could have a free DHT of 12, and one of them could have a free DHT of 3. So one of them could have 4 times the amount of free DHT that's actually binding that receptor. The analogy I'd use for that, so total DHT, when SHBG binds it, it's like in a straitjacket. It's not let loose. So insulin will cause all of that DHT, or not all of it, but a lot more of it, to be let loose, and then it can actually bust down the androgen receptor door, and that's going to certainly lead to scalp hypertrophy. I forget the name of it, but it's something like cutaneous gyrase something. It's like the muscles are so hypertrophied that it looks like the brain.
Yeah. And so that there definitely is some connection there. It's just about what is the connection, because there's even evidence that shows that the muscles, the erector pili muscles around the hair follicle actually degrade. But the question is it because of the disease, or does it help contribute to the disease? And so it's the same with when you look at a lot of disease states, there's this whole causation versus correlation type of debate that has to be had. And I'm not sure if there's any conclusive, decision there. I do know that of the medications that are approved for hair loss for androgenic alopecia, finasteride and dutasteride are of the most effective. Now, of course, they're also associated with a small degree of sexual dysfunction. And so a lot of men are really kind of hesitant to just jump right in. Although I'll say myself, I've taken finasteride since I was about 27 years old, because I was super anxious about losing my hair, because my dad lost his hair and a lot of people on my mother's side lost their hair. And so I was super nervous, especially when I was like in my early 20s, 21, and my friend laughed while he was filming me from a bridge on looking down, and he said that he was finding it funny for some reason that he could see my scalp and that I'm going to lose my hair. And so that got me all paranoid. And so I've been on it, and I actually recently switched over to dutasteride, actually at the recommendation of Dr. Day, because you have to take it less frequently because there's a longer half-life. And so, but the real question is, I don't really have a lot of hair thinning, although just like any male, I have thinner hair than I used to when I was younger. But the real question is, are these things healthy for us long term? Like, is blocking DHT really something we want to do? Is there something else the hormone should be doing for me that I'm not getting that benefit because I'm blocking it? Do you have any insights there?
Yeah, so DHT has nothing special about it compared to testosterone, except that it is better at busting down the androgen receptor door.
Gotcha.
So if you happen to be born with a androgen receptor that is a heavy metal door, and by the way, this is on the X chromosome, so males can thank your mother, which you inherited your X chromosome from. And yes, your mother got one of her X chromosomes from her father.
That's right.
So theoretically, that's the link between, people have heard you inherit your hair of your mother's father.
Right.
You have a 50% chance of having the same X chromosome and therefore androgen receptor as your mother's father. So the more sensitive your androgen receptor, the more likely you are to have fast progression of androgenic alopecia, and the more likely you are to have fast growth of prostate cancer. But you are more likely to have no symptomatology without DHT. So even if your DHT is very low, the analogy I make for DHT is it's like plumbing in your house. You have 3 different rooms. This is oversimplifying, but it's kind of helpful for the purpose of medication. Finasteride inhibits your type 2 room, type 2 isoenzyme. Think of that as your hair follicle and your pubic skin. So genitourinary skin. So males and females both have pubic skin, but that's the type 2. Type 1 and type 3, and that's mostly what finasteride works on. Dutasteride mostly works on type 1 and type 3. Think of that as non-genital skin. And then think of that as also hair, but also other things like liver. So each cell has a different proportion of these 3 different isoenzymes. But to complete the analogy, your bloodstream is a pipe that connects all 3. We only measure DHT in the pipe. But what causes the actual symptoms is a level of DHT, for example, in your central nervous system, which finasteride can affect to a slightly larger proportion. But some people, that's a benefit because you'll have more estrogen in those cells. So if you tend to have lower estrogen and higher DHT, or you're more sensitive to androgens genetically, you'll respond very well to finasteride and dutasteride, as I have as well, by the way, personally. But if you're not, then you're more likely to have symptoms of hypogonadism in the tissues that it inhibits. So with finasteride in your central nervous system and in your genitourinary system, you're more likely to have hypogonadal symptoms in disproportion to other symptoms. So that can be very disconcerting to some when they're noticing changes in like the sensitivity of pubic skin versus non-pubic skin. And then with dutasteride, there's no dutasteride syndrome, but the dosing is very different. It has a dose-dependent half-life, kind of like Tylenol, where if you take a very high dose of Tylenol, it's metabolized very slowly. Dutasteride's the same way. So that's why the dosing is so important, as Doris mentioned.
Right. So the hypogonadal, is that manifested by like atrophy or by symptoms like sexual dysfunction?
Symptoms like sexual dysfunction. Some people do notice changes in the genitourinary system, but a lot of that has to do with the blood flow. Okay.
So let's go to Seti, because Seti's hearing all these words that are very medically technical, and I want to think from a consumer perspective. How much of that did you catch? Because I want to hear what like a consumer can catch from this type of dialogue.
Right. It was like there were a couple of words that I did not understand, but as you were explaining it and as you were going forward, I could understand the pretty good amount of it.
Okay.
So now I know there's a relationship between the hair loss and the
cancer.
Which was
prostatic cancer.
Yeah, which was very interesting. I would never thought there was a relationship between those. And I had a question.
Sure.
About spotty hair loss.
Okay, so that's a different type of hair loss, and we can talk about that in a second.
Okay, that's a whole different type?
It is.
Okay,
and
it
so,
affects whole different things.
So from your perspective, when you think of hair loss, is that what you think of?
I never experienced a hair loss before, but I've seen the people that I've seen, and I don't have anybody in my family that experienced the hair loss. But only thing that I've witnessed was the people that they go through stress, like my friends or people around me. I've seen them going through the spotty hair loss.
And we'll talk about that.
That's kind of more familiar for me.
Okay.
So I was curious, anything else than stress can cause that, or like what is the cause of it?
That is a great
where is it coming from?
Transition to the next kind of topic here. And so, Kyle, I'm assuming she's talking about, things like alopecia areata and such that is more spotty in nature. So why don't we get into that? And then stress-induced hair loss, that's actually something that I've seen a few of my friends also undergo when they have loss of children and such. That type of stress can cause some thinning of hair. So why don't you give us some of your thoughts on that?
Yeah, with the alopecia areata, I would put that in the category of autoimmune. And usually this is very circular and it's very patchy. Sometimes it goes away, sometimes it comes back. The kind of the classical treatment of this is intralesional corticosteroids, which is basically kind of like prednisone, but of another version of it injected into the area. So it is associated with autoimmune disease, and there's actually a new approved medication that is essentially an immunomodulator that people can take for very often when this is very severe. That's what would be recommended. And there were some pictures circulating, and there was phenomenal results for that medication. But that medication does not cross over and also treat other types of hair loss. This is not one of the more, it's not uncommon, but it's not common. But alopecia areata and the more classical autoimmune type hair loss is certainly a different category. Another one that we should mention is tension alopecia, which is also not necessarily related. And again, Hickham's dictum, which is basically a patient can have as many pathologies as they darn well please, means that yes, there could be a patient that has all 4 of these pathologies. But tension alopecia is basically a long period of time with lots of tension in the hair that slowly leads to hair loss because of that tension.
Right. And so I think to the layperson, did you get that last one? Because that's,
if we can make it a little bit more simplified.
Because that's something that actually most people don't get, especially women, is that when you, and ballerinas actually notice this because they put their hair in a really tight bun. And so when women put tight ponytails and tight buns and they do that day after day, it can actually cause recession of the hairlines because the tension on the hair can actually cause that hair to just die, I guess, the follicle to die. So it's called tension or traction alopecia. And so you see this also in African-American women and men who use, what's it called, cornrows, because they do the tight braids.
Oh, yeah.
And you can see that the area between the braids actually gets bigger and bigger because they start getting hair loss that's associated with the tension of those braids. So it's not advisable to wear your hair tight for long durations of time or often, because you can actually get and now Kyle, do you know, is traction alopecia reversible?
I'm not sure. I would
either.
assume that it's reversible to some degree as long as the stem cell has not migrated out of the area.
Right. And the real question is also whether by doing that, are you actually pulling the hair, the skin back that doesn't have those terminal follicles and stretching that and then shrinking the area that does by kind of contracting that. I don't know the answer to that, but that's a very interesting thought there. And so did that answer your question about the spotty?
Yes.
Right?
And I have one more question now.
Sure.
So now that we said pulling the hair strongly can affect the hair loss, what about the wearing a cap or something? Does that
That's a good question.
It can. This is debatable, and there's not really a great evidence-based recommendation, but wearing a cap all the time likely does lead to faster progression. We do not know if that's due to, you wouldn't think it's necessarily traction, but pressure. Yes, you could make that case. And then also changes in the microbiota. So
because there's a lot more fungus.
Fungal infections or subclinical bacterial infections. Theoretically, this person would be washing the hats and such as well, so maybe that would make it a bit better. But especially if they're doing it when it's very humid and with lots of moisture, then that's one of the theories behind why ketoconazole, there tends to be some hyper responders for the ketoconazole shampoo.
Okay. Yeah, and so that's very interesting. I actually hadn't thought of that, the relation of the fungus to alopecia. Of different types. And so it's interesting because one of my passions is you might get anybody who watches this podcast knows I bring everything back to the microbiome and to the skin biome. And so that's something that I hadn't considered before, although I knew that there's association of microbes with people that have different forms of alopecia. The real question is, to your point, is it the chicken or the egg? Is it causative? Is it correlative? Because is it just because of the different environment where if you have hair, you're probably holding in more moisture because it's just the way that hair sits on the head versus, if you don't and it's completely exposed and there's lots of different variables there. So that's interesting. I'll have to look into that a little bit as well. So now I guess let's transition. I mean, let me ask Jose, do you have any questions for Kyle about this?
I have a few. Can we talk about a little bit the myth you brought up?
Yeah, what's the myth?
So another myth I heard is blow drying your hair can make your hair fall out, or walking around with damp hair and then just using a towel right after getting out of the shower to dry your hair off can cause your hair to fall out. Are these just myths, or is there any truth behind them, or are they just wives' tales that get passed around and around?
So Kyle, you can't see, but we have the peanut gallery back there with Dr. Jose Maldonado and then Alan. And so could you hear that question?
Yes.
Okay.
Yeah. So to answer one part of the question, would drying off your hair very vigorously with a towel cause more hair to fall out? Acutely, yes. So a lot of the hairs that are kind of done with the telogen phase, it's very common for them to come off in the shower or in the towel. But I wouldn't consider this to be likely to lead to the progression of whatever hair loss. For example, male pattern baldness, it's not likely to lead to a faster progression of that. It's just going to be like daylight savings. You're going to have the hairs are going to fall out earlier rather than over the next week or so. As far as keeping your hair wet all the time, I would say that would kind of fall into the bucket of theoretical with, does wearing a hat all the time cause faster progression of the hair loss? So you could make the case, and this is a pretty decent analogy in my opinion. If you take a female with no male pattern baldness predisposition and no cause of telogen effluvium, and you have them have their hair wet all the time, and you also have them wear a cap all the time, and vigorously dry their hair after a shower, that they will not have any start or progression of hair loss. So a lot of it is still related to the activity of the androgen binding the androgen receptor in the case of male pattern baldness or androgenic alopecia. But the speed of which, like how early the follicle falls out, sometimes they make another analogy, hair years to human years. So some medications, of course, prolong a phase like anagen phase. But when it goes through anagen, catagen, telogen, let's call the average hair living 80 human years. The average hair on, let's say, minoxidil, let's say they live 150 human years. And the average hair that is wet all the time, where you very vigorously dry your scalp, perhaps that's 70 human years. But the hair is like, you're not having more hairs lose their stem cell or be permanently dead, but you're just having kind of like a shorter lifespan of the hair.
Yeah, and I don't want anybody listening to the podcast to think your hair actually grows for 80 years. That was just for an analogy.
It's like dog years and human years. Yeah.
Dog years? Did you hear that, Tikers? Dog years.
Can I ask one last question?
Sure.
So I have a few friends that are males that are, that are bald now, and they always tell me, well, the reason I'm bald is because I have lots of testosterone. So is that true? Or is that false? Give us your final saying here. Can you settle the debate for us?
It's not true.
Within normal levels of testosterone, it is definitely not true. However, if you look at an individual who has been hypogonadal their whole life, by choice or otherwise, then it is unlikely that they will have fast progression of hair, but fast progression of hair loss, that is. But no, that's not true. It's mostly just related to the sensitivity of their androgen receptor or things like insulin resistance. So perhaps they're more likely to have prediabetes or prostate cancer, but they're not more likely to have a high normal testosterone level.
Right. One thing is there are people that abuse steroids, or HRT, people that abuse HRT and or hormone replacement therapy and use abnormally high levels of testosterone for bodybuilding purposes. And those people, the question is, do those therapies that are abused lead to progression of hair loss? Because one of the things that they advertise for those therapies is for if you are losing your hair by taking HRT, you can actually restore hair. I'm not sure I agree with that. I think that's actually more marketing than it is science. But what is your take on that?
Yeah, this is a very interesting concept because if you take someone who presumably requires hormone replacement therapy, for an example, let's take a 45-year-old male who's hypogonadal, very low testosterone, very low estradiol. They're not aromatizing. By the way, aromatizing is just the conversion of testosterone to estrogen.
Mm-hmm.
That's how males get the main estrogen, which is estradiol.
Mm-hmm.
They could have female pattern baldness, which a lot of, it's kind of like maybe not a great term, but let's call it low estrogen hair thinning. They could have very thin hair.
Mm-hmm.
And when they start HRT and restore to a normal level, so they're not abusing this, but they bring things back up to a normal level of testosterone that converts to a normal level of estrogen, then they can have an improvement in the quality of their hair. Many people notice that hair is also growing faster. For example, during pregnancy, your level of estrogen increases a lot. So when you start HRT, your level of estrogen can also increase, which is good. So a good rule of thumb is that as long as you're not getting breast cancer or endometrial cancer, more estrogen is usually better in both males and females. There's a balance to all things, of course. But on the other end of that, a very high level of any androgen, including synthetic androgen, will bind that androgen receptor and lead to progression of male pattern baldness. The important thing about HRT is that when usually this is injectable HRT or topical creams, you're at a steady state. That means your level of both testosterone and DHT is relatively stable,
Mm-hmm.
whereas naturally there's peaks and troughs.
Right.
So
like in the morning,
over time, that androgen receptor, back to the door analogy, it never gets a break if you're on HRT. There's always androgens trying to break through. So that's why often you see more progression of maybe better quality of hair, but certainly faster progression of androgenic alopecia, even at the same level of androgen in the serum.
Okay. So now we've talked a little bit, you actually brought something to my mind when you talked about the fact that you can, if you have hypogonadism, you could actually have, I guess, what you called female pattern baldness or just thinning of the hair generally. Do you have any knowledge of, for instance, I remember back when I was listening to David Sinclair when he had his short podcast series, and they were talking about eunuchs who basically lived like, I think 20 years more than the average male. And they're saying it's because of the lack of the hormones. So do you have any knowledge as to whether they experience that type of phenomena with a thinning of the hair, or is that just a completely different, because they never even hit puberty? It's a different story, you know?
Yeah. So a huge rabbit trail that we could go in with eunuchs, but of course they still have adrenal glands. So in the adrenal glands, especially at younger ages, you can produce very high levels of DHEA, which can convert downstream to estradiol. So they might have relatively normal estradiol levels. Also, they have less feedback suppression. So because they don't have high levels of androgens, then things like ACTH could be slightly higher, which can lead to both DHEA and cortisol production. But if they happen to be someone who has an early adrenopause, which is where your adrenals stop working, kind of like menopause, but for the adrenals, it's not a precipitous drop, but it does happen over age, then they would be more likely to develop a female pattern baldness or hair thinning, but they probably have a Norwood 0 score hairline because they haven't been exposed to androgens.
That's right.
So you probably wouldn't be able to tell unless you weren't looking from the front.
So that, you just taught me a brand new term that I had never heard before, which is adrenal pause. Now I'm going to have to go and figure out what that whole story there. But we don't want to go down that rabbit trail too much. What I do want to talk about next is how integrative medicine can help to prevent or treat hair loss. But how do we use that to help prevent hair loss? You know, because we talked a lot about genetic predisposition, stuff that we really can't change at this day and time about ourselves. But like you and I, we can do medical prevention by taking things like finasteride or dutasteride. But there are people that have side effects from some of these medications. And it can be to where they really can't tolerate whatever those side effects are. I have been lucky enough to where I haven't had to deal with that, but not everybody's that lucky. So what do we do integrative medicine wise?
Yeah, this is where an individualized approach comes in. So there's several things that I look at, but depending on the individual, I might do a more intensive workup or a less intensive workup. But at bare minimum, for an individualized approach, I will want to look at the estrogen to androgen ratio. And for most males, that means so there's a couple different basically types of lab tests, and one of them is an immunoassay. And it's kind of hard to understand this as a layman's term, but most physicians don't order the right estrogen test. So it's inaccurate. You don't really know if you're high, low, or middle estrogen, but you at bare minimum want to look at your estrogen to androgen ratio. I've posted these tests on your website that you can take to any regular doctor. And as long as they're willing to order an estrogen, presumably he or she would be willing to order the accurate estrogen. And then you also want to look at your progestogens. So the way I explain progestogens is they do a lot of things throughout the body, but the important thing that they do in the central nervous system is act as something called a neurosteroid, DHP and THP. They are likely the cause of a lot of postpartum psychosis and postpartum depression. The treatment for that is THP, and DHP would also likely work. But just like you have testosterone convert to DHT, you have progesterone convert to DHP, and it has to convert to DHP to cross the blood-brain barrier. So when you block a lot of that 5-alpha reductase enzyme, a lot of it's in the liver, by the way, it's not going to cross the blood-brain barrier as much. And the symptoms of the central nervous system symptoms of finasteride syndrome or a dutasteride syndrome are often pretty similar to postpartum depression. Fortunately, replacing something like pregnenolone and or progesterone, if indicated, can improve this from time to time. And sometimes even something like a creatine supplementation can improve this because it increases the levels of hepatic, which is the amount of the enzyme in the liver that can convert this so that it can cross the blood-brain barrier. I haven't thought of a more simple way to explain it, but as long as they're checking those different things, and again, I put this on my website, the different lab panels that you can request before starting the medication. That way you can look at your levels before and after and see how it's affecting you.
And what's your website for the listener, just so they can have that?
GilletteHealth.com, and then there's a lab panel option.
Okay. So, of course, Dr. Gillett is a practicing physician. And so on the podcast, he's not going to give any medical advice, but if you're one of his patients, then he will be more than happy to do so. So make sure you remember that this is all for informational, educational purposes. And if you really need to dive into integrative health for yourself, if you're losing your hair, it's something that I think he'd be more than happy to have a talk with you as a physician one-on-one. Or he would probably prefer you find a physician closer to you if you're not in his area. But I don't know, Kyle, do you do a lot of telehealth these days? So do you do any of that?
I do some telehealth, but I do prefer to see people at least once in person is kind of a nice touch. But I do telehealth. It just kind of depends. But yeah, I think from a 1,000-foot view, my main emphasis for the lab panel options is just making people aware that if you have a lower level of estrogen, so males or postmenopausal females, the common test that's ordered is not accurate.
Right.
So that's the main reason why I posted it. And I think I explain that on every podcast I go on. So hopefully people at least glean that.
No, I think that's very important, is that I am a firm believer that we as a society need to remember that science and medicine progresses. So as we learn more, we can do better. It's not that we did things wrong, 40 minutes, but it's that we, just did the best with what we had. But there's a certain time where you're like, this wasn't sufficient. We need to do more. We need to do better. And so it's actually on your podcast when you asked about, do you have a single takeaway? After we got off, I said, the takeaway I probably should have said is that, which is the thing I always say about, from Doris, I used to think it was her quote, but it's actually Maya Angelou's, which is, if you know better, you can do better. And that's really my takeaway, is that we shouldn't be resistant to change in medicine and science. If we have evidence that shows that we have ability to do better, we should not resist. And unfortunately, I think a lot of it stems from insurance reimbursement and all that stuff, because the government doesn't like to reimburse new things because they're typically more expensive things. And so it's part of this movement. I don't know what you think about concierge medicine, but it's becoming more prevalent now because people are wanting to, say, I'm willing to spend more money on my health as long as I get better advice. that is not just because this is what is reimbursed, but because this is actually what's better for me. And so I know I'm going to look at your website and actually take it to my, because I do concierge medicine, and take it to my physician who is more open to new things, and saying, if I approach him and say, I talked with Dr. Kyle Gillett and he advises that you look at this panel, he's going to order that. It's probably going to come out of my pocket. But the thing is, I want to know that I'm in the best situation with my health, because you only have your health until you lose it, right? So you're your best health advocate. And so I tell that to my parents and my dad all the time.
I have a question.
Yeah, sure, Alan.
I always hear about shampooing and conditioning and stuff like this, if that affects any hair loss as well. Use expensive shampoo or not, use conditioner or don't. So, and I have, most of my life I had long hair and curly hair.
He still does,
and it looks real pretty also. And but you know, I've always wondered if there's anything has to do with, because there's time that sometimes I lose hair and I can just, when I shower I notice, and then it goes away for a while. I would just wonder if it has anything to do with shampoo. And I try to kind of change my shampoo on a regular basis, you know, and stay with kind of a better ones.
Yeah, that's a great question. By the way, I had very long hair for a while until I cut my hair shorter after I finished residency. But and I used to cut and color hair as a hobby for many years.
What? Interesting.
And I rarely do so.
Your own hair or everybody else's hair?
Men's and women's hair.
Ah, interesting.
Yep. So yes, I suppose I've probably had regrets about products that I've used on myself and others in the past, but that leads us into shampoo and conditioner and whatnot. Depending on your skin type and depending on your hair type, there is such a thing as too much, which I think we mentioned there's that for everything, right? But it seems like a lot of people who really try to care for their hair are doing too much shampoo or too much conditioner, or using a product that has too much surfactant or too much foaming. Basically, foaming does not necessarily mean that the shampoo is doing better for your hair. And even some shampoos like ketoconazole shampoo that's prescribed can cause your hair to be extremely frizzy. Mine becomes frizzy very easily.
Mine too.
So for that, I just use an individualized approach, with the caveat that most people are probably doing so too much.
Yeah, actually, so Alan, I think one of the things he said earlier was a lot of people, when they don't wash their hair every day, the hair that is falling out already naturally, that is supposed to fall out, actually collects. And so then it looks like you're losing hair, when that's just, you lose hairs naturally all the time. And so when I was a kid, I used to hate this because I grew up with two sisters, and they would wash their hair and pull out these globs of hair and stick it on the wall of the shower because they didn't want it to go down the drain and clog the drain. And I would get in the shower because we all shared a bathroom, and it would make me gag. I mean, that was so gross. I can still remember. It's just so gross. But it's one of those things where if you wash it every day and you have short hair, you're probably not going to notice a lot of hair loss. But because one of the things I notice is when I cut my hair really short, I never see the hair come out on my hands, because it's just, you just don't see it. It actually falls out and just, you never see it. But when your hair grows, it gets more tangled up in your other hair. And then so when you actually are washing it and you're actually running your fingers and combing through it, it actually will accumulate. You can actually see it more. So I think a lot of people, I get nervous about that sometimes too. When my hair starts getting longer, I'm like, am I losing my hair now? But it's like, no, it's just natural. All right. So I think that's pretty much where we're gonna stop things as far as this discussion. That was actually a great discussion. A lot of things that I did not know from a cell molecular level even. And so first thing I'm going to do after I get home today is look up andropause. No, what was it? Adrenopause.
Adrenopause.
Yeah, because that's new for me, and I now need to know what that how long that's going to take for me to hit adrenopause. Anyway, so Kyle, where can they find you online if they want to learn more about you or follow you on socials?
My main hub is Instagram, Kyle Gillett MD, and Gillett Health on all other platforms.
Okay. And don't forget his website, which is GilletteHealth.com, correct?
Yes.
Okay. And then where can they find you, Seti? Because I know that you're a social media mogul of sorts, right?
Yes, you can find me on Instagram.
Okay.
And my username is Seti Gucci, SETY. and underscore Gucci, Gucci.
And she is a very interesting person if you'll follow her. She's actually half Japanese and half Persian, right?
Yes.
And
yes.
so she's got a lot of really cool things that she does, places that she goes. So she didn't do a lot with skin science on her Instagram, but not everything's about skin science. So I'm Tom. You can follow me. I'm Dr. Thomas Hitchcock. You can follow me on Instagram at dr.t.hitchcock. And you can, of course, go to Crown Laboratories and follow them on Instagram and all social medias as well. And so I'd like to thank Dr. Gillett for joining us today for this discussion. And also thank you to Jose Maldonado, Alan, and Seti. And until next time, we will see you later. Bye for now.